Good morning. Thank you for showing up after heavy dinner and party last night. So, thank you. And may I now request Dr. Chandrasekhar Meshram to kindly introduce Professor Riadh Gouider.
Good morning. It's a great pleasure and honor to introduce my friend, Professor Riadh Gouider from Tunisia. Professor Riadh is currently head of Neurology Department at Riadh University Hospital for last 20 years. He is head of Alzheimer's Center since 2010 and multiple sclerosis centers since 2018. Riadh is very active in World Federation of Neurology since 2005. After serving as elected trustee for 6 years, he is currently co-opted trustee of World Federation of Neurology. He is currently co-chair for the World Congress of Neurology 2023 in Montreal, Canada, co-chair of the Teaching Course Committee, and he is co-chair of the WFN Education Committee. Riadh is also one neurology ambassador since 2021. He is member of the expert group of WHO. He is member of the specialty groups of WFN of rare neurological diseases, migrant neurology specialty group, and environmental neurology specialty group. So basically, he is a man of organizations. He is the president of the Tunisian Neurosurgery College since 2018. The member of ALS Research Project since 2012. Expert member in International Small Fiber Neuropathies Network since 2015, and member of CMT International Database since 2015. After completing his MD Medicine in 1993, he obtained the Diploma in Neurology in 1994. He did his Masters in Human Genetics in 1999 and Diploma in Clinical Neurology from the famous Salpêtrière Hospital, Paris. And it's no wonder that he's very proficient and fluent in 5 languages: Arabic, Italian, French, Spanish, and English. He received various awards. At the very early age, he received American Academy of Neurology Foreign Scholarship Award in 1994, European Academy of Neurology Special Service Award in 2018, Pan-Arab Union of Neurological Societies Award, and 12th Maghrebian Meeting of the Neurology Award. He has more than 250 publications in international journals and book chapters, e-learning days, and he organized 3 e-learning days, and is chair of local organizing committee of World Federation of Neurology, the World Congress, which happened in Dubai in 2019. He is a member of EAN Task Force on Gender and Diversity Issues in Neurology. He is the honorary president of Pan-African Association of Neurological Societies and Pan-Arab Union of Neurological Societies. From 2014 to 2018, Riadh was president of the Tunisian Society of Neurology. So he is a very multifaceted, interesting and personality with interest in organization, research, education. So ladies and gentlemen, please welcome Professor Riadh Gouider to deliver Professor J.S. Chopra oration.
Thank you, Dr. Chandrasekhar, for this very kind introduction. Mr. President of the Indian Academy of Neurology, Mr. Elect President, Mr. Trustee of the World Federation, Mr. Treasurer, and all the delegates here. It's my pleasure to make this oration of the late Dr. Professor Chopra. The link between the presentation and you see a lot of interest, and you say how we can have so many interests. The link between them is genetics, and you will see how. First of all, I cannot begin without saying a few words on Professor Chopra. I've known personally Professor Chopra, and I even voted for him. I can confess this now when he presented. Unfortunately, that was time very difficult for developing country to go in. And now I think that with discussion of yesterday also, you say that the things have been changed also a lot. Professor Chopra is also a very, very good friend of our master Professor Ben Hamida that I will present. I know him, he was very active in WFN, so we hope that we will make just a little part of what he has done and to follow his example. We'll speak about neurorecessive diseases and how they impact our practice. It can interest some part of your country, depending on the culture and the tradition of people. But look in the world, you have, is there a pointer? Tunisia is this I'm sorry. Tunisia is there. And you see all the MENA region is with high consanguinity rate. India also in some regions have consanguinity rate. So this is impacting neurology, and you will see how. I said that if you see autosomal recessive, they are impacting even sometimes more than the dominant diseases in our country. And it has an impact of loss of function, of protein dysfunction, of disease phenotype, which can be allelic. And as you see on this paper on frontiers of neurology and this on nature communication, there's now a trend to understand better what's happening in recessive disease, because a lot of what it is considered sporadic cases are in fact recessive diseases. I will begin with a recognition of one of the friends of Professor Chopra, Professor Monji Ben Hamida, the founder of the Tunisian Neurology. He was in Salpêtrière. We are French-speaking neurologists, and the majority, will have a training in France in Salpêtrière, where Charcot was. And that gave a solid school of neurology in our country. When he came from France, he just was studying, very interested on muscle and nerve. And he studied families. And he described what I translated in French, it's muscular dystrophy, progressive dystrophy, type Duchenne. And he was writing recessive autosomic thing. And this was, I wanted to show this and to show what's happened. When he came back from France, he was astonished to have these Duchenne-like patients. But not only the girls were affected, the boys also were affected. The males were affected. And what was, the males were affected, and the girls, you see here, the hypertrophy. And he said there's a problem because it's Duchenne-like presentation, but involving males and females. This is what the phenotypal description he had. And this is the pedigree what we have in Tunisia. Look, this loop of consanguinity. It's something that make you sometimes being very worried about the type of inheritance. It's a severe form mimicking Duchenne myopathy, mild form like Becker myopathy, but even a benign form. And when Professor Ben Hamida presented this in the World Federation in Amsterdam in '73, he was said that he was wrong and that he should examine better his patients. He was a very good friend of Lord Walton. Lord Walton was a former president of the WFN, a very known person in muscle, and he made the classification of the limb-girdle muscle dystrophies. This is Professor Walton. He was a friend of Tunisia. Professor Walton came himself to Tunisia, examined with Professor Ben Hamida the patients, and said, and gave the warranty, I will say that was the first. After this, it was never been needed for our neurology. That there was a girl, Duchenne-like type. And the work has been going on. What's happening? You have the dystrophin, but you have here all this complex. If you don't have this complex, dystrophin will be not linked to the membrane. So either you have a loss of dystrophin in Duchenne, or you have a loss of this complex, you will have the same phenotype, nearly. But it is recessive autosomal. And there was a several description in our countries of this type of limb-girdle muscle dystrophy. How it changed our neurology? We have gone from this description of limb-girdle dystrophy on now subtype of limb-girdle dystrophy linked to the genetic gene implied. If you have LMG22C, now even the names have been changed. It will begin on the second childhood with a normal intellect, and you can have severe phenotype in half of cases, intermediate phenotype, and it is linked to this deletion. This deletion is not only Tunisian, it's in all the MENA region. It came, everyone thinks that came from Saudi Arabia and crossed all this country, and now is the most frequent. When we see a girl with such presentation, we go searching this deletion from the beginning. And in the majority of cases, we will find it. But why make it easy when you can make it complicated in recessive disease, which is the hallmark of recessive diseases? You have several types of sarcoglycanopathy. I've showed this and showed the alpha, the beta, the gamma, and the delta sarcoglycanopathies, and also the dystroglycan complex. All these sarcoglycanopathies, I say, will give you the same phenotype with a mild to severe presentation depending on the mutation. When we have a limb-girdle dystrophy, we go specifically to beginning by the 2C, and after this, we see the others. This is the kind of publication that have been done by the Tunisian school on limb-girdle muscular dystrophy 2C, 2E, 2E, and this is, and I said, we cannot make it sample in recessive disorders. There's families where you have the both genes. There's a so huge consanguinity that you can have the two genes on the same family. And this has published now 18 years ago in neuromuscular disorders on genetic heterogeneity within a consanguineous family involving LGM2T and GM2C. So we have been from a description of a girl-like, Duchenne-like dystrophy to several phenotypes that we are observing in our population. And these phenotypes now, we go searching specifically the gene. I'm going from the muscle to the brain. And we did the same thing on hereditary neuropathy type Charcot-Marie-Tooth. I began working on these diseases in Salpêtrière 92. And at this moment, there was only 3 loci of Charcot-Marie-Tooth disease. Since the description of Charcot and Marie in 86 and Tooth in 1886, the Charcot-Marie-Tooth disease has been described with the inheritance pattern, the clinical presentation. And I will just say, it's a funny story of how neurology has also evolved. At the beginning, there was this clinical presentation, and then come after this, the people of genetics, the population genetics saying, look, you are wrong. This is Charcot-Marie-Tooth disease, but you have dominant, recessive, and X-linked. And after this, with the discovery of the neurophysiology said, you are wrong. You have this pattern of inheritance, but you have also demyelinating type and axonal type. After this come the guys of the anatomopathology, and they says, you are wrong. You have in the demyelinating autosomal or recessive forms with demyelination, but form with hypermyelination. And after this come the people of the molecular biology. And from the 3 loci, I have just to show you the recessive form, how many loci we have. You have now not to be a neurologist, but to be a Charcot-Marie-Toothologist, to know the 100 genes that are involved in. And if you see the recessive pattern, it's just when we have a Charcot-Marie, just begin, how I will begin to discover this gene. It can be demyelinated, it can be axonal, X-linked, and even motor type. This is a lot of paper that have been described, but I will just for sake of time stick to one of this subtype, which is the mutation in MTMRT3 genes. What the story of the family? Look, this loop of recessive. What happened? The grandfather was collaborating with the French colony, and they gave him a part of land, a huge part of land in his village. And to keep this part of land undivided, they just married between cousins. So they presented in this generation 4 cases of neuropathies, demyelinating neuropathy associated with glaucoma in the 4 cases. And we were it was very striking. We did the inquiry in the at home. We have gone with an EMG machine and did the EMG for all the families. And we did a lot of data. But when we asked to come again, they said that, please do not come. We said, why? They said, when you come and you examine us, no one of our daughter was postborn. So the people saw that there is a pathology in this family, and they didn't even marry from the village from them, because they know that have been genetic. So from the cultural aspect of having this land not divided, you have arrived to Charcot-Marie-Tooth disease, a severe one, linked each time to a glaucoma. That's the neuropathology with hypermyelination in this type. What's linking this glaucoma and this neuropathy? After discovering the MTMR3 gene in our family, we are working on this. What's the link? The link is that the trabeculum, which is responsible of glaucoma, and the myelination derived from the neural crest. And there must be, most probably, a mutation that involves the functioning of the neural crest and can, that's where, make the glaucoma and the neuropathy. And even if you see this focally folded myelin sheaths on autosomal recessive Charcot-Marie, you have several types. So from a phenotype, we have been gone to the description of this association, and now we are working on the pathophysiology and the etiology of this. There's several other genes in neuropathies and Charcot-Marie-Tooth. And if you see this axon and the myelin around, you have the MTMR3, the lamine, and the GDIP1. The GDIP1 is a form that we have also described first in Tunisian family, and you see how severe it can be. You see the hand of the patient. When we have now early onset in childhood severe phenotype, we go searching for GDIP1. And frequently we find this mutation. Another type of mutation, when you find scoliosis, or so severe scoliosis, we go to see the CMT4C with the mutation on the KAAE gene. That's how we are going now from neurology again to genetics and how it changed. Even for the lamine, it's more complicated. It can give a myopathy and it can give a neuropathy. I said to you, for the recessive disease, you cannot make it simple. It's always very complicated, and we are facing, even in families, patients with myopathies and patients with neuropathy. That's so what we have learned from the recessive hereditary neuropathies and how they impact our neurology, the clinical presentation, searching for specific mutation in our population. I'm going now to another story, the Inverich-Lundborg disease. When we speak about progressive myoclonus epilepsy in India, I think that Lafora is the most frequent. Am I wrong? That's what I have in papers published from India, because we compare this to our population. In our population, when we have a progressive myoclonic epilepsy, we go searching Inverich-Lundborg disease. It's a recessive disease, and I will show you. Is the video working? Excuse me. I'll show you again. I have another video working. It's working. Look, he is having his hands because he has myoclonus, and he falls several times. So he works very slowly, and he has this myoclonus. When we see this, we go to Inverich-Lundborg in Tunisia. You see how it can be severe. The story is a very interesting one. It was described in the Baltic countries, and they called it the Baltic myoclonus. It was described in France and in North African country, and they called the Mediterranean myoclonus. But what was the link between both? It was simply by the genetics, the same disease. There's no Baltic myoclonus nor Mediterranean myoclonus. There's Inverich-Lundborg disease. From where came the difference between the two? The Baltic countries are very cold countries, and these patients are very fragile, and they die often of pulmonary infection. So they have a shorter life expectancy in the Baltic countries. So it was described as severe. Moreover, there are differences on how we prescribe. The French school is with phenobarbital and Depakine. The Baltic school of neurology is treating with phenytoin, but phenytoin is very toxic to the cerebellum. And this was worsening the cerebellar syndrome that these patients have. So giving them phenytoin was aggravating the clinical presentation. And this is where you have two different phenotypes from the same gene, but due to the environment. In fact, it was the same disease. And we describe it in several cases. I said that it is 8 on 147 cases in a study in India. Lafora was more frequent. So the cystatin B gene with the expansion of a dodecamer, we show you an example of how the recessive families have and the multiple cases that we have. We have studied the genetics and are searching what it is very strange in this family, the phenotypical variability. You can have, now that we have the genetics and we know who has Inverich-Lundborg and not mutation, we have expanded the phenotype of this disease. I will show you how. Look to this family. This is the video that we have added to the techniques, if we can have it working. It's a very important video. We added in the file. Can we have it as a video? Can you have it from the file? It's also on the file. We just look, 15 years, able to work with difficulty. She's able, but you see that you have some difficulties. This has 22 years, a more severe working difficulty. The same family. But the third is wheelchaired. Even he has 16 years. She is younger than the 22 years, but she shares, and they are on the same family, on the same environment. This died from a pulmonary infection already. And we are very interested to understand why on the same family we have so phenotypic variability. And we are still working on a group of genetics, and we wanted to study this beautiful family. And these are the video that are linked to. They were working when we tried them. Can I have this video? When we made the test, it was working. Okay, we published this family. When we see the family, it was like a juvenile myoclonic epilepsy, and we have gone wrong. We have gone this family on searching of a new gene. When we made the genome, it came that it was a progressive myoclonic epilepsy type in Richland-Borg. And we were very surprised by this clinical examination, which was really very, very mild. And it was very mild. So what we have been done all this year now is just to show how you can have such variability. This lady, more than 50 years, they have Richland-Borg disease with the mutation. But when you see how things are, she's really able to have she has some myoclonus. But even this family and other families don't have even epilepsy. This is a family, progressive myoclonic epilepsy, but with genetic deterioration and without epilepsy. I will not go by form in sake of speaking about other disease. We are not only showing cases, but we tried with valproate and clonazepam and giving them baclofen. You remember this guy who was working with difficulty with this combination, because we are not able to have very expensive drug for them. With this small combination, we were able to have this modification and to improve the case. You see, he is able now to working by far better. So, with these treatments, now we are following patients for a mean age of 25 years of follow-up. The epilepsy is disappearing. The myoclonus can be stabilized in 90%, but nevertheless, 10% of them will be bedridden or will have a death before. And you see how the EEG with the treatment is just with age improving and with the condition. So these conditions, now we have expanded the phenotype. When we have a juvenile myoclonic epilepsy, we go to search progressive myoclonic epilepsy type in Richland-Borg, and we can improve them by the treatment. That's what we have learned from Richland-Borg disease in our families. I will show this patient. This patient was sent to us from the psychiatry. They thought at the beginning that she was psychiatric. She has psychiatric signs, but it came out that it was not psychiatric. Guess what is? Autosomal recessive. It was Wilson's disease. When we have a child in our country with movement disorders, with some, I will say, peculiarities, we go to searching Wilson's disease. And this is, I say to you, how recessive disorders changed our way of thinking on there. And we have enough elements to show by the examination, the ophthalmological examination, the MRI, signs that orientate, and we go to search the ATP7B gene. Another case. Look, when we have in our consultation a child who comes with this, we go directly to one disease. Guess which is this disease? It's a disease that is found in our region only. So I understand that you don't know it very well. It's ataxia with vitamin E deficiency. That's something that we have, which is recessive. And when we see, and now we expanded this and we have colleagues from outside, because we have a lot of migration from our region to Europe, that's saying us that with this knowledge that we are improving even this. I want, if I have still a few minutes, to tell you the story of the vitamin E deficiency and how the neurogenetics helped us. The recessive consanguinity we have gave us a group of ataxia with Friedreich phenotype. And with this Friedreich phenotype, we have gone to search genetics. And surprisingly, Professor Benhamida and Professor Hintati and the co-workers find two groups. One was linked to the Friedreich locus and the other not. But they have the same clinical presentation and they were on the same group. And it turned to be a vitamin E deficiency with low serum of vitamin E. And why it is so important? This disease is treatable. When you give them vitamin E, you can solve the issue and you can have them improving if you are not too late. So when we see ataxia, we don't go to Friedreich, we go first to vitamin E deficiency and we make the dosing of the vitamin E in the blood. And it's more frequent in our country than it is. So from a phenotype of Friedreich-like ataxia, we have two groups. One which is treatable, the vitamin E deficiency, and one which is less treatable, even we have some new drugs, which is Friedreich ataxia. So we cannot miss this, and we have to make the diagnosis for these patients. And this has been also discovered, and one of my colleagues, Professor Blair, took the American Academy Prize for this work. As I say to you, recessive cannot be simple. This is a family with 3 distinct gene defects in a single consanguineous family. Even if you have a family, if one have vitamin E deficiency, it's not sure that the SIB has another deficit vitamin E deficiency. It's probable, but it's not sure. And you can have like this, Friedreich ataxia, AVED, which is vitamin deficiency, and Arsax in the same family, as the consanguinity is so important. In the few minutes I have to finish, I will just give you a glimpse where we are going now. We have, as Chandrika said, the first Alzheimer's center in Africa. It was an opportunity for us to go now, and we have now a series of 6,000 patients with Alzheimer's disease, Tunisia being the oldest population in age in Africa. And what was striking in this Alzheimer's center, we have, as I said too, is the early onset. 1 patient on 4 have early onset dementia. You have 2 possibilities. One of them is that you have a center effect. It's a bias because you are a center, you are known. If there is any case which is not, I will say, in the norm, they will send it to you. So that's surely bias by this, but that's the only fact. We have gone more deeply on seeing these families. And we found that familial Alzheimer's disease is 1/3 of our patients. And if you go more in depth in this, you will find that's the APO gene, but I go to the recessive on this. If you have the autosomal recessive form, you have several families with early onset and recessive inheritance aspect on the pedigree. This is not 42 families, while the papers from Italy, Japan, and Spain were speaking about 1 family. That's very important to follow. And it's not a view of our spirit only. There's this paper in 2012, published online, autosomal recessive causes likely in early onset Alzheimer's disease. That have been described 10 years ago. And we are working on this because it implies not only, I will say, if I have the slide, it implies not only the genetics, but implies the presentation form. If you have recessive, you will have more behavioral troubles. And these things we are working on to better identify this. Another glimpse which is rapid, the LRRK2 mutation, pink one. It's 2% in India, most probably, or in other countries. It's 30 to 40% in our country. When we have an Alzheimer and Parkinson's disease, we are searching LRRK2 mutation. 1/3 of our patients have LRRK2 mutation. It's a dominant. So why I put the LRRK2 mutation in this presentation? Because in our department, for example, we have 20 homozygous patients with LRRK2 mutation. With consanguinity, the patients are homozygous. And we are working on this group to see if homozygosy is giving a more severe phenotype, or it will have an impact on the treatment. Whole England, because we are working with England on this, with an English group on network. All England had 120 patients of LRRK2 mutation. In our department only, it was on 10 departments in Tunisia, we have nearly 300 patients in one department. So you see, if you have a mutation in Park disease, we have to work first on this and to see if the homozygosy is giving a more severe phenotype. And as you see, this have been published 10 years ago, consideration regarding the etiology and future treatment of autosomal recessive idiopathic Parkinson. We have to do the work because we are very involved on this recessive disease. But we also, with the last slides, working on MS and recessivity. And we have several families now with MS, several cases affected by MS, but also a recessive phenotype. And I will conclude on this slide, solving the unsolved. Recessive disease in neurology, expanding the spectrum of neurological disorder, mimicking autosomal dominant form. And this, we have to look to the pedigree. We don't forget that you have among them treatable conditions. I spoke about Wilson disease, vitamin E deficiency, Inver-Schönberg disease. We can improve this patient. It's not a fatality. We have to work on this. And this is a window to understand from the pathophysiology to the treatment. You have as many mice models that you want, but mice is mice and man is man. And this is not applicable every time. You have just to see what happened in the vaccine and Alzheimer's disease. So we are trying for our patients to improve because we have very specific conditions, very local conditions, and no one except us can work on this because simply these are our patients. With this, I thank you again for the invitation, for the opportunity to speak, and for this marvelous meeting. I never thought that it will be as usual. This, as I said, I will try, me and Richard, to report to the World Federation Trustees meeting next time, how this meeting is huge. And thanks again what you are doing with the World Federation of Neurology in the World Brain Day and in other activities. Thank you.
Thank you, Dr. Riadh. Now it's time to honor you. We close this session.
Thank you, chairpersons. Now for the next oration, that's the NSI presidential oration. I'd like to call upon Dr. Lakshmi Narasimhan and Dr. Vineet Suri to chair the session. We'll just start the session in 5 minutes.